Many have dreams to be a medical professional. When choosing an institution for medical school, a lot of things matter. The quality of the academic and clinical programs, as well as the clinical experience. At Unimas, we offer that and more. A supportive culture, a vibrant community, diverse student and patient population, all set against the backdrop of Kuching and Kota Samarhan.
The culture here is welcoming. It is a big family. Everyone wants the next person to succeed together. We want our students to reflect back to the society and the community today. As a community-driven university, we believe that immersing themselves and ourselves in the diversity, it creates better innovation and greater creative achievement.
In Unimas, there's not a culture of a competition here, but a great environment is what we all strive for.
Everyone is committed to create a great environment to become a great doctor in the future.
Our patient population in Malaysia is remarkably diverse. Different languages and dialects will be something that we face every day once we become a doctor. So, getting to know this and learn it now make us to be more appreciate and respect. It just set us up to become a better doctor for the future.
From the beginning of the program, 25 years ago, we have adopted a spiral curriculum. As the students advance forward into their years of clinical study, we connect everything back to underlying basic biological sciences. We connect and revisit every aspect of human health, from emotions to diseases, back to its basic biological sciences.
We are introduced to clinical setting early in our curriculum. The exposure gets more as we advance through the year. It was very daunting at first, as a first-year student to step into hospital and seeing patients. But at the same time, it's really an exciting experience.
We are committed to excel in nursing education, research and practice. It views health as a complex and dynamic and the client as a holistic individual. Students in this program learn in an environment that stimulates intellectual inquiry and creativity, which encourages them to be problem solvers and lifelong learners.
Here, we learn how to care, to serve and to help. We went from zero to hero.
I really cannot pick a better place to learn and become a greatness. This is a place that belongs to my heart throughout my journey.
Come do research with us.
Come and join us at Unimas and realize your dreams.
Hi, good morning, everyone, and welcome to the UNIMAS Second Health Talk Series 2022. My name is Dr. Ng Boon Han Kevin from the Otorhinolaryngology Head and Neck Department, Faculty of Medicine and Health Sciences, UNIMAS Malaysia, and I will be your moderator for today's session. Before we begin, I would like to thank the organizing committee for organizing this Health Talk Series, which we hope will benefit all the viewers here today. The topic today is Doctor, my kid can't hear clearly. What should I do? It's a very interesting topic, which I'm sure everyone can't wait to listen to. Just some housekeeping announcement. All participants are requested to type their questions in the Q&A chat box, and we will answer them at the end of both speakers' presentation. Together with us here today, we have two very experienced and distinguished speakers. The first speaker is Professor Dr. Tang Ing Ping, who is a UNIMAS alumni. He graduated from the second batch of UNIMAS medical student. He completed his clinical and research fellowship in otology, neuro-otology, lateral skull-base surgery, and advanced endoscopic skull-base surgery. He is the past president of the Malaysian Society of Otorhinolaryngology, Head and Neck Surgery, and is the current president of Sarawak ENT Society and Sarawak Here. He's also currently the head of department of the Otorhinolaryngology department, a senior consultant in Sarawak General Hospital, and a visiting consultant in Borneo Medical Center. The title of his talk today is Hearing Loss in the Young. Professor Dr. Tang, the floor is yours.
Thank you, Chairperson. I'm Dr. Kelvin Ng. Thanks for the organizing committee inviting me to give this talk today. So my topic today is basically hearing loss in the young. I'd like to share my PowerPoint here. So I know sometimes, quite a number of times, some patients come to ask, when actually is the best time do we need to screen to my baby if they have a hearing problem. So I give you a very general view of if you have hearing loss in your family members, like in your babies or in your children, whatever it is. So what you should do next year. So this is my topic today, hearing loss in the young. So before we start, I just give a very brief view of anatomy and physiology of hearing. So at least we have better idea what actually happened in your have the problem of the hearing loss here. So the ear, I always mention we divide to three parts here. So the external ear, this is external ear, then middle ear, and the inner ear. So external ear basically from the pinna until the tympanic membrane. Middle ear is basically from tympanic membrane until the middle wall of the middle ear. And the inner ear is basically a cochlea and the vestibular systems here. So like I talk to you now, how do you get to know what I'm talking and how do you understand what I'm talking here? So we need to know about how the sound being transmitted to the ear. So basically when the sound coming in, you will basically all concentrate and then funnel into the canal here, passing through ear canal. This is basically is a sound energy. When hitting the tympanic membrane here, it changed to the mechanical energy, which is transmitted by these three ossicles until it comes to the oval window. So oval window, that is connected to the middle ear, connect to the inner ear. So when come to the oval window, come to the inner ear, the fluid there change from mechanical energy change to hydraulic energy, moving the hair cell inside the cochlea here. So when this hair cell is moving in the cochlea, it will transmit from basically hydraulic energy to electrical energy and transmit to this cochlear nerve and come to the brainstem and come to the temporal lobe. So if any problem in this pathway, if you have any problem in this pathway, then you may have hearing problem. Like I mentioned just now, ear will always divide to three parts, external ear, middle ear, and the inner ear. So if the problem is arising from the external ear and the middle ear, then you will have so-called conductive hearing loss. If you have problem in the inner ear, cochlea, and the vestibular system, as well as the cochlear nerve here come to the brain, then you will have sensory neural hearing loss. So let's give a very brief view about quality of sound. I think a lot of people will ask, how much, what is the decibels of the sound that we make here? So I give you a very brief guideline, so at least you know if someone cannot hear with this kind of level of a hearing, then you roughly have some idea how much the hearing loss is. Okay, so normal hearing frequency is between 20 to 20,000 hertz here. The usual frequency that we hear is around 500 to 4,000 hertz if you have going to hearing test. So you know the four most important frequency that we always check is 500, 1K, 2K, and 4K. So this is where the sound range that we always needed for us to communicate daily. So the loudness of the voice, if you're whispering, you know around 20 to 30 decibel. If you can't really hear someone whispering, even though it's very near, less than 20 cm, then you know that, okay, or 2 meter, you know that basically the hearing loss is around 20 to 30 decibel. Let's say normal conversation level I'm talking now is around 30 to 50 decibel. If you're shouting at you only can hear, that means you roughly have hearing loss up to 60 to 70 decibel. So anything above 90 decibel is actually danger to your ear. So don't expose to the loud noise, which is more than 90 decibel in your into your ear. Then you will have, okay, very soon you have progressive hearing loss. So hearing loss, we have general view about sound, how it transmitted, how the component of the ear. Now we come to how do we classify the hearing loss. So hearing loss, basically, you can divide to organic and non-organic. Non-organic is basically, I don't talk today, it's basically mainly to psychiatric problem. Organic cause, this is what we're going to emphasize on today. Like I mentioned just now, you can divide to conductive, which is if you have problem in the external ear and the middle ear. Sensory neural hearing loss, this is where you have the problem in the cochlea and the nerve. Okay, so this is sensory neural hearing loss. If you have both together, then you will have a missed hearing loss. I just capture again, revise again. Okay, where is the problem is? If the problem is the external ear canal, like I mentioned just now, then you will have the conductive hearing loss. If you have problem in the middle ear diseases, then you will have conductive hearing loss. So this is the audiogram. If you're going for checking by the audiologist, they will do a proper audiogram for you. So this is the audiogram that you will see. A bit complicated if you are not, if you don't have any medical background, you might have problem to understand about this. But never mind, I just give a very brief idea what is that. Normal hearing is basically less than 20. Less than 20. Anything that if your hearing is at this level, basically you have normal hearing. Usually this is basically a bone conduction and this is an A conduction. So most of the time, bone and the A conduction, they will be in the same line. So if you have any gap in between bone conduction and the A conduction, that means that, okay, you have some sort of conductive hearing loss. That means the sound can transmit via bone conduction, but cannot really transmit to the A conduction. So that is basically you have some conduction problem here. The bigger the gap, the bigger the large airborne gap, then you have a problem with the more serious conductive hearing loss. From 20 up to 40 is basically anything above 20, below from 26 up to 40 mild hearing loss. 40 to 70 is moderate hearing loss. 70 and to 90 is severe hearing loss. More than 90 is basically profound hearing loss. Doesn't matter it's conductive or sensory neural hearing loss. So these are the causes of conductive hearing loss. I won't go into detail, but just to mention again, anything happen to the external ear and the middle ear, you will have this conductive hearing loss. For inner ear diseases, like I mentioned, okay, just now, if you have inner ear diseases, then you will have sensory neural hearing loss. Anything happen to the cochlea and the cochlear nerve, the tumor in the cochlear nerve, or any injured to the cochlea, then you will have inner ear diseases, then you will have sensory neural hearing loss. So for audiogram, for sensory neural hearing loss, basically the 2A conduction and the bone conduction, they still will be in the same line. Okay, they are still coming together, but they are away from the normal level. Normal level I mentioned just now, below 20 or below 26. So this patient for this one is basically at the 40. So basically this patient have moderate hearing loss. Then progressing, getting worse in the high frequency, like say 5,000, 1,000, 500, 1,000, 2,000, 4,000. These are the four main frequencies that we need to hear in our normal conversations daily here. So from here, so if 1,000, you can see it's around 50. It's already in the more moderate hearing loss. It comes to high frequency, it's already in the severe sensory nearing hearing loss. So for this audiogram, you basically have some idea how bad is a hearing loss, because we need to have proper audiogram in order for us to get idea how do we help a patient with a hearing loss. So the causes of sensory neural hearing loss, a lot here. Congenital acquired, I won't go into detail, but just remember, anything happen to the inner ear and the cochlear nerve, you will have sensory neural hearing loss. This is a chart that I mentioned just now in order for you to really classify how bad is the severity of the hearing loss. How bad is a hearing loss? Doesn't matter it's a conductive or sensory neural hearing loss. You divide like what I mentioned just now. Like 40, 70, moderate, 70, 90, severe, more than 90, profound hearing loss. Because different level of hearing loss, you might need different kind of hearing aid to help you, or even which is hearing aid can't really help you, then you might need hearing devices, which is implantable hearing devices to help you for you to get back your hearing and so that you can communicate using the verbal communications. So let's come to clinical presentations here. This is quite important for children. So for children, why I keep on mentioning that we have to detect early, because the brain of child, they are fully mature most of the time after 3.5 to 4 years old. So if you have intervened before 3 years old, or before 4 years old, I mean 3 years old below, they will be the best, the patient will have the best outcome. That means before the brain mature connecting together, especially the speech and the hearing component of the brain, before they are connecting each other together, you try to intervene them, you try to link them together using other source of hearing devices if they can't hear properly. So you intervene early, you detect them early, you intervene early, they can back to verbal communication like you and me in future. So there's a reason hearing loss in children is emergency for you to get back the verbal communications if you want to intervene them early. So early detection is always very, very important to pick up. Then we screen to, then we do the proper investigation, proper workup before we give them a definite treatment or management. So newborn baby, they can't tell you, I can't hear. Your baby newborn, 1 or 2 months, okay, less than 28 days, they can't tell you, oh, mom or Bob, I cannot hear. So that's why you need a universal newborn screening. This is something that you need to have. Most of the country, we have a lot of countries that have it. Malaysia, we also have universal newborn screening in more of the big hospital. Even in Sarawak here, all the three big hospitals, we already have universal newborn screening. Some of the private hospitals also going to that direction here. So why you need universal newborn screening, and what is universal newborn screening? Means that the newborn baby, when they deliver, doesn't matter what happened to the baby, they will be screened too. Before they discharge, okay, from the hospital to make sure that they can hear. They can use a simple way, OAE, auto acoustic emissions, or they can use a very more complicated one. But of course, need more expert doing that. So the simple way, the nurses, okay, in the maternity ward, in the labor room, what they can do is they can do an OAE to check through whether fail or pass. If you fail, most likely you have no problem. If you pass, that means most likely you have no problem. If you fail, then you need to repeat the test again, screen through them again, or seen by the audiologist to proper checking, measure that they are really have no ear problem. Because sometimes fail in the beginning, after you repeat few times, okay, you can get past and no problem, But most of the time, if you fail, you need to screen through again. So they will give you an appointment to come back to see ENT side, to see the audiologist, to have a proper screening, proper ear checking to measure that there is no hearing problem, then we can intervene early. So this is part of the early detection. But sometimes you miss this part, or sometimes they have a delay problem. It's not a prelingual. They might have speech initially, but slowly after some time, 6 months or a year, they'll notice that they can't really talk much. They have a speech delay. So any children that we have problem by a year, which is can't really speak any word, you better go and check. don't think that, people say, oh, never mind, I can just wait for another 1 more year because my another daughter have a problem with the speech. Also get by 2-3 years old, only know how to speak. Maybe we just can wait again. I'm not against mother-in-law, but always mother-in-law theory always say you have to wait for a while. Okay lah, don't go and do something. You wait for a while to make sure that they can learn some more, do something. But I found that sometimes because of that, you miss the boat. You really miss the golden period, okay, that you can help the children. So if you think that the child, which is, doesn't matter, you notice that your child, doesn't matter you are medical personnel, okay, sometimes the nurses in polyclinic, sometimes the nurses in maternity clinic, they might also advise patients just wait for a while. But no, you don't do that, okay. If you have problem, if you found that, okay, any kids have problem with speech, okay, or listening, always refer early and then for the proper checking to make sure that there's really no speech delay for that. Of course, if the child have high risk in the high risk group, any children, any newborn in the high risk group like preterm, neonatal jaundice, congenital infection, meningitis, syndromic features, or any history of the head trauma, all this group you have to have a proper screening, like patients in SEM or patient in this intensive care unit. All the patients after the discharge, we will have made an appointment to see them, to check in the newborns, to check in the audiologist to have proper hearing screening. Of course, your family history of hearing impairment, then you have to measure that. Basically, you have to screen to them to make sure that the families or other members won't have this kind of problem. Why I keep on mentioning about this? Because this is a statistic which is very important. 1 to 5 baby in 1,000 usually have some sort of the hearing loss. And then among these 1 to 5, 50% of them might need implantable hearing devices to help them to get back the verbal communications. And 50% of these hearing loss children, there's no identifiable risk factor. So that means they're just born normal, they look normal until you find that they have speech delay if you don't have a proper newborn hearing screening from the beginning. I'll just share a bit of the Sarawak statistics here. So Sarawak birth rate from 2017 to 2019, basically around 36,000 baby per year. So you're based on whatever that WHO giving the statistic. So roughly 1 year, we have around 200 babies have newborn screening. Just imagine out of that 200, maybe around 50 of them need proper hearing assessment, need proper investigations, and also interventions in order for them to get back their hearing. So it's a big number here. So we need to basically check through. This is just a very rough idea, the statistic about what happened in Sarawak here. Like I mentioned just now, universal newborn screening is very, very, very important because if unrecognized and untreated, you basically deprive brain auditory informations, then you basically delay the speech, language, and learning development, and of course, at the end, affect an educational opportunities and the social lifestyle. Also, if a children, if a baby, after they can get back their hearing, they can back to verbal communication and they come back to community, then they will contribute a lot to the community here. So these are general guidelines for universal newborn screening. Usually by a month of age, we try to identify the hearing loss by 3 months, got early intervention by 6 months. Like I mentioned just now, the early you intervene a child with a hearing problem, the better outcome in order for them to come back to using verbal communications. So a lot of studies actually have done. They found that early implantees, especially patients need implantable hearing devices. The performance is comparable to normal children at the same age, because the main thing is ultimately you want them to enter the mainstream school, and also you want them using the verbal communication and come back to what is norm for community in this world. So what kind of tests that we would do? What kind of the relevant investigations that we would do for the children, for the child who have hearing problem? So for the hearing assessment, like I mentioned, OAE, you can use that. Then evoke a response, BERA, so the child will sleep, then you basically check it properly. This is more objective test. Clear audiometry, pure tone audiometry for bigger child. Timanometry, imaging, you can do a scan or MRI. So this is just a picture or photo, how it's being done. This is basically OAE. This is basically done in the screening part, in newborn screening, in maternity, in labor room. This is a play audiometry, so you can see some of the child can actually obey the command. They actually can give a different frequency and different decibel hearing. Then they can basically using to pick up, to give them a task that they will do. So they can understand the task. So that means that basically they can hear properly. This is a normal hearing test that we have done using the both PTA. So whatever sound they give you, just like does not play audiometry, of course, it's not a task, it's just a sound, give you a signal with a different frequency, different decibel, then you hear from them. This is the BERA. This is basically, it's a test, more objective. Sometimes you see the child need to sleep, okay? You need to give them to sleep to have more objective tests, because some children just really cannot basically cooperate with you to have a proper hearing test. So you need a BERA to help them to gain a proper objective hearing test to see. So come back to the hearing devices. So we have gone through all the things that I mentioned. So come back to hearing devices. What kind of hearing devices that you can use to help patients, to help a child with a hearing problem? Like I mentioned just now, you still divide the ear to external ear, middle ear, and the inner ear. So this is the most important classification in order for me to manage all the hearing problem, in order to intervene them with the hearing devices. So for the external ear, basically you can use a conventional hearing aid. Like I mentioned, conventional hearing aid is always a gold standard in the treatment of the hearing loss, provided you have sorted out all others hearing diseases that you need to go ahead with some surgery. Let's say you have tympanic membrane perforation, you have cholestoma in the meantime because of the diseases causing the hearing problem. Then you have to sort it out all the diseases there. Cholestoma, you have to do a proper surgery. Tympanic membrane perforation, you might need to repair. So after repair or after remove the cholestoma, you still have the problem with the hearing. Then you come back to see what kind of the hearing devices is suitable for you to let them to get back their hearing. So hearing aid, the normal hearing aid is still the gold standard for any patients with a hearing loss, unless when the hearing aid can't really help you, then you have other choice. You have osteo-integrated hearing aid, which is for patients who doesn't have a pinna and also doesn't have this canal or canal atresia. So these are the patients that you might need implantable osteo-integrated hearing aid to help them to hear. You have something called middle ear implant. You can put the implant into the ossicles, okay, poking together for you to hear, especially if patients can't really using a normal standard hearing aid. Okay, then the next one is cochlear implant. This is very, very important and quite known to this society. Cochlear implant, the history less than 50 years in the whole world. So actually helping a lot of patients, a lot of people come back to hearing, come back to normal hearing. Basically, you put the implant into the electrode in the cochlea to bypass whatever happens in the cochlea, which is can't transmit the sound to the cochlear nerve, provide the cochlear nerve and the brain is normal. You actually can help them, okay, to get back the hearing. Afterward, I will share a few video clip how a patient with the cochlear implant, how they get back their hearing. And lastly is a brainstem implant, auditory brainstem implant. If you have problem from the sound to transmit from the cochlea by through the cochlear nerve to the brain, you have problem with the transmitted to the cochlear nerve here, you can directly put the implant into the brainstem there, in the cochlear nuclei there for you to hear. So right here we have quite a number of patients using it. The outcome, most of the patient, the outcome is quite good as long as you select the patient which is really indicated for this kind of hearing devices. hearing aid, like I mentioned just now, is a gold standard. Whatever hearing loss, you have to try. You have a trial with the hearing aid first. There's a different type of the hearing aid. I think the audiologist is the best person to tell you. You have in the ear, you have in the ear, in the gonga, behind the ear, all sort of different kind of the hearing aid. Depends on how much is depend on how much is the hearing loss, depend on the severity of the hearing loss, then they will prescribe you with a different type of the hearing aid. Audiologist is the best person to give you the best fitting hearing aid for you to try to help you to magnify the sound to hear properly. Let's come to cochlear implant. So cochlear implant is something which is, like I said just now, is still quite new to this world, less than 50 years. I think Sarawak here, I think less than 15 years, we have implanted quite a number of patients here with a hearing problem. So this is the basically the internal component. You implant, put this electrode into the cochlea for you to hear. So this is the external component here. So this external component is for you to fit outside. How they link together? They link together by the magnet. So coupling induction by this magnet here. So surgery, ENT surgeons basically put this implant into the electrode, and this is beneath the scalp. So once the wound or the scalp is healed up nicely, you can't see the internal component. So this stay linked by the magnet, the sound processor. This sound processor basically to receive the sound, okay, and then passing the sound to the receiver here, then you can hear. Once you take it off the external component, you can't hear at all. You need to put this external component in order for you to click into the magnet, click into the receiver for you to hear. So you take off this one, you have nothing can see it in the scalp, okay, because this implant is basically hidden, buried beneath the scalp nicely, so that you can't have any problem. A lot of patients asking me, do I need to change this internal component? No, you don't need to change the internal component for your life, okay? Just sometimes maybe you have a very severe accident. Imagine if a very severe accident can injure the receiver, injure the electrodes here, that means the accident the huge impact is big enough to basically injure the brain too. So normally we don't need to change the internal component. The external component basically is depend on the advancement of a technology. Bear in mind, this sound processor external component 30 years ago is as big like a bat. Now smaller, now with the advancement of technology, getting smaller and smaller, and even now, just one click at this kind of size here, you actually can hear. So something that which is really good for you to get back your hearing using this kind of technology. What basically are the indications for cochlear implant? I think it's quite straightforward. If you can't using hearing aid cannot help you, a patient receiving the profound hearing loss in both ears, then it's a time you can use a cochlear implant. You can't get any benefit from the hearing aid, and bear in mind, if you only put the implant on and don't go for proper rehabilitation by speech and audio, that is useless too. So you really have to attend a proper rehabilitation sessions. That means that the parents or the caretaker or patient itself really have to motivate to attend. We need to relearn back the way of hearing. Our brain is very clever. So once you relearn back the technique, okay, the hearing process, then the brain just adapt it. After some time, you will just sounds like normal hearing. So you need to go for the rehabilitation. Without speech and audio, no matter how good the surgery is, no matter how perfect the surgery being done, you still can't hear, you still can't talk. So you need to go for proper rehabilitation session. This is the most important in the whole surgery, in the whole management of patients with cochlear implantations patients. So I share with you a few video clip of a patient which is prelingual patients implanted less than age of 12 months old. See how's the good outcome. So this is a patient after 18 months of the implant.
3、4、5、6、7、8、9、10.
He's very big now. He's already entering mainstream school. these patients, both parents basically they are deaf. Okay, they can't speak. So it's a grandmother actually noticed the problem and then picking up, then bring him to see me, and we intervene. So now he's already, I think, 7 years old. He can talk, but he also learns that language because he want to communicate with the parents too. So he just thought like a normal people. Just imagine without this kind of hearing devices. Basically now he just like their parents have to using the sign language to talk in their daily communications way. So another child which is implanted at the age of 16 months. This is after 3 years of implantations. He's very good now, also entering mainstream school. He's very big now, I think 8 years now. Also even can speak 3 languages quite well. This is a video clip that he sent to me by his mother. So you can hear, basically, his pronunciation is quite very good, okay, after implant this child. He's doing very well in his school now. So another child which is implanted at the age of 5 years old, because a bit delay in the beginning, ultimately with the proper counseling. So you see, he still can speak, but you can compare to the previous two. I think you can notice that, okay? Yes, he can speak, you can hear properly, but the pronunciation you can see, there's a big difference here. So that's why I always say that you really need to detect them early and intervene early, then you can give them back their hearing better. They can speak more words, they can speak full sentences and communicate with verbal communications. So you need this group of people to help you for your rehab. Without them, there's nothing will happen in the cochlear implantations here. So this is about cochlear implant. We have others implantable devices like this bone bridge here. Like I mentioned just now, bone bridge is an oscillated hearing implant. You can use it for a patient with a conductive hearing loss. So these are the patients that usually you need this kind of hearing devices to help you, because they are basically, it's a microtia. Can you see that there's no ear canal? So they can't hear properly because the sound can't really transmit to. The sound has to really huge enough, okay? You really have to speak very loud for them to hear. So in order for them to hear like a normal people, you need something implantable devices implanted at the behind here or above here at the scalp region, so they can directly transmit the sound and get back the hearing. So a single-sided hearing loss also can use that, okay? Sometimes can use a cochlear implant too. So we need to further investigations. Then we see what is the best for the patients here. So these are adult patients which is implanted with a bone bridge here. We pick up these patients during some hearings campaign in one of the shopping mall many years ago. Then basically we managed to get in implant sponsor implant, the bone bridge here. So basically you can see this is the airborne gap from the beginning. So after implant, you can see come back to normal the hearing. So he told me actually he never heard people talking so clearly after 23 years of his life. I think now he's already almost 30 years old already. So we have published some of the data with the children with the congenital oral atresia. So you can screen to, you can go to read to if you are interested to know more about this. Then you can read through in the Journal of Laryngology and Otology. And also we have reviewed the bone bridge in the tertiary center in Malaysia here. So you actually can go to this and you can read through too. And lastly is a Branson implant, this is very new. The first implant in Malaysia we're actually doing in Kuching, Sarawak here. We've implanted almost I think at the moment for the adult, we have implanted 5, 6 patients. Children, we have 2, 3 patients. So patients implanted, the outcome of them, of course, we need to really select the patient which is really indicated in order to have a good outcome. Like I mentioned just now, you put the implant in the cochlear nuclei there for you to hear. So what are the indications for this? But basically, like I mentioned just now, in most of the patients, for the postlingual patients, you have tumor like NF2 in the cochlear nuclei there, or but your cochlear nuclei is still normal. In the cochlear nerve, there's some growth or tumor there, and the cochlear nuclei is still normal. So it's the best patient, bilaterally, it's the best patient to use this auditory Branson implant. Of course, you need to do together with the neurosurgeons for you to put the implant into that. The outcome is quite good. Prelingual, so if the patient without a child without cochlear nerve, then it's an indications for you to put the implant in, as long as you others there's really indicated there's no others problem in the brain and all sort of things there. You need to screen through them. It's a bit complicated. You need to screen through them, counsel the parents, and get the whole thing to come in together. We discuss together whether the child is suitable for this kind of hearing implant. So I'll just give you an example of a patient, which is this patient is basically having meningitis because of that is a defect in the skull base. So she have 1 by 1 hearing loss, which is you can't put a cochlear implant into the cochlea because of the meningitis causing the cochlear ossifications there. So the only way is bypass the cochlea. We put the implant into the brainstem, into the brainstem and the cochlear nuclei. The outcome is quite good. This is patients after 6 months after switch on. He basically can hear me talk. I'm sitting at the end of the left side. She didn't look at me. She looked at the front. You can hear. I talked to her. It's the loudest voice I have at the time. My video record is not that good. Mak lah. Oh, okay. Baguslah ha. Sekarang dengar macam mana? Bagus, anjing ke, kucing ke, itu suara kamu boleh kenal kah? Semua boleh kenal sudah. Kucing boleh, anjing pun boleh. Semua boleh kenal sudah. She almost lost her hearing for the past, I think, 3 years before she decided to go for that. Initially, she refused because she's quite scared to put the implant in the brainstem. But after counselor, sometimes after she feel that it's really, really difficult for her to have communication, then she come back again. Then she come back again to see me. Then she want to go for it. Luckily, Sarawak government sponsor these patients. We get the money from the Sarawak government to help her to get back hearing. She's very happy now. I think now it's more than 5 years already. She's doing quite well. Just on and off, need to check her sound processor because of the battery, whatever is there. Once everything checked, replaced, so she can hear quite good. She's quite delighted to have this kind of hearing devices. Despite of initially she don't really keen to get this kind of implant into her brain, but she feel that she just didn't not regret doing that because there's something that can help her to get back her hearing. We actually have published some case report, some data. You can read through in Malaysia Medical Journal. So the outcome is quite good for this. Of course, you need to choose the proper patients to go through this kind of complicated surgery. So my conclusion for today, for my talk, is basically you have to detect early. Whatever is, you have to check the child, the children, especially the children in newborn baby. You detect them early, so you intervene early, then you can bring them back to the further communication. So I repeat again, the most important thing is if you have any problem, if your children have any problem with the hearing, go and check, detect early so that we can intervene early to bring back to the verbal communication. So with that, thank you so much.
Thank you, Professor Tang, for the very, very informative talk. As Professor Tang mentioned earlier, so detect early so we can intervene as early as we can, and the outcome is good. All right, you can put on your questions in the chat box. We will answer it at the end of the talk today. So we'll move on to the next talk first. The next speaker is Dr. Dayang Suhana, also a UNIMAS alumni. She graduated from the 3rd batch of UNIMAS medical students, completed her postgraduate degree in University Kebangsaan Malaysia, and she's currently a senior lecturer in the Otorhinolaryngology Department, UNIMAS, a practicing consultant in Sarawak General Hospital, and a visiting consultant in Norma Medical Center. The title of the talk today is Common Ear Infections. Without further ado, I'd like to invite Dr. Dayang to present her talk.
Good morning, everyone. Can you hear me?
Yeah, loud and clear, Dr. Dayang.
Hello.
Yep, we can hear you.
Yeah. Can you see the slide?
Yes, we have seen you started your screen sharing.
Hello. Hello. Can you see the slide?
It's still being loading.
Kevin, can you
Yeah,
see
it's
the
still
slide?
loading up.
I can't hear you.
It's still loading.
Okay, hold on. Okay. Is it okay now, Kevin?
Still loading up.
Hello.
Still loading up.
Yeah, it's still loading up.
Yeah, the internet.
Okay, while we're waiting for the screen to load up, there's one question here for Professor Tang. Does a 2.5-year-old kid, if you notice they like to speak or shout very loudly, is that considered to have hearing problem?
Okay, so for these questions, for me it's better you have a check, because sometimes it's just a sometimes I won't straight go and say, oh, it's a behavior because of like to shout, whatever is there. You know, sometimes a patient which is a child which is any patients who have poor hearing problem, especially adult, they try to speak very loud. And you might thought that they are very rude sometimes but they can't really hear. So if you think that, okay, a child, but you can notice it, you can, when the child not shouting, whatever it is, but if you're shouting all through the whole day when talking to the child, then you better go and check. But if the child is not shouting, and you can talk to him, whispering, talk to him in normal conversation, he can understand. That's mean maybe the hearing is normal, but in order to play safe, whatever is there, you can always bring them to have a check. You always can bring them to have a check. There is audiologists in the town, okay, in the private side too, in the government side too. So you always can bring them to have a check, make sure that the hearing is normal. So while the hearing is normal, then basically you know that maybe you need to have some to see some pediatricians to see any problems, okay, with behavior, the kind of things. So first of all, if you are doubt with any problem with the hearing and speech, always bring them to check. I mean, Kuching here, I mean, quite accessible. You always can bring them to check. Quite accessible to have audiologists. I think most of the bigger town in Sarawak is quite accessible for you to see the audiologist, to have a hearing check. If you have any problem, always can come to the ENT. We always will examine and refer properly to the proper personnel that we can help you for the hearing assessment.
Okay. Thank you, Professor Tang, for answering the question. I think Dr. Dayang Suhana, your slide is back up. Once you're ready, you can start your presentation.
All right. So good morning to all the viewers and the panels. Today, basically, I'm going to talk about the common ear infection, basically both in children and also adults. So before I proceed with my presentation, I would like to just explain a few common words which I'll be using. Yeah. So ear pain basically we refer as otalgia, whereas ear discharge we will refer as otorrhea. So most of the children will present with painful discharging ear. So again, brief anatomy of the ear. As you can
Sorry,
see,
Dr.
it's
Dayang,
divided
do you
into
mind
three
putting
parts.
your slide
Yeah.
to full screen?
It is in full screen already. It's in full screen, Kevin.
At the moment, we are seeing the first slide, the title slide, common ear infections.
Okay. All right. How about now, Kevin?
Still the first slide.
Okay. Hold on. But it's okay in my slide, yeah?
Yeah, we can see, but I just need to full screen it.
Okay, wait, hold on. Can I just stop for a while?
Yeah, sure.
Yeah, all right.
While we are
Sorry for
waiting,
the technical, yeah.
no problem.
Yeah.
While we're
You
waiting
can proceed
for
with the question first, Kevin.
yeah, with
Yeah.
Dr. Dayang's slide. Just another question for Professor Tang to continue with the question earlier. Based on your previous experience in seeing parents coming in with kids who cannot hear, at what age normally do parents notice there's something wrong with their hearing?
So is most of the time, if they have gone through the newborn screening, then they always refer back by the audiologist to us. So we will see them usually less than 6 months. But if parents detect early, from the beginning, before we have create more awareness, I mean, this is basically mentioned in Sarawak area, we have before we create more awareness, I have seen my patients, parents bring the child coming in to see me by the age of 3 years old, 4 years old, 5 years old, 6 years old, 8 years old, 10 years old, any age they have come and bring me. But after we have done quite a lot of hearing awareness, and of course I found out they will come early. They will come early. They will come maybe like 1 to 3 years old. Most of the time pick out 1 to 3 years old, but sometimes it's accessible for them for the hearing assessment, especially when they are from rural area, maybe a bit part of the delay. But in the big city, most of the time they won't have any problem. They usually will come within 1 year to 3 years time. So that's why we need a very quick assessment. We have very quick interventions to help them. And some of the parents, they bring over the child to see, but the problem is they're still in the denial stage. Okay. Again, mother-in-law theory coming again. A lot of mother-in-law, parents-in-law, no lah, no worry lah, give some more time. I have quite a good few example. Because of the parents-in-law, and then keep on delaying the child for almost 1 year, 2 years, ultimately disappear for some time, and then come back again. I have a very true story to share. There's a patient initially detect very early by 6 months because of father-in-law, mother-in-law come and intervene in. So ultimately disappear for almost a year, and then come back after a year. They really found out, my grandson is really cannot talk and hear like normal people, normal other children. Only then we start interventions. That's at the age of, but he bring very early. So at the age of maybe like below 2, 3 years old, the outcome is still good. Now still can talk and hear like normal. Not only one, a few, 2, 3 patients like that, ultimately when the child and the children can hear, and then the parents-in-law feel a bit regret. Okay, I think parents-in-law, I think only one, come over and say, I'm really sorry about this. Others, they just like, when the face look at you, they feel very embarrassed like that. So just keep quiet lah. So the ultimate conclusion, the ultimate message to bring home is, if you think that a child have problem with the hearing, or even in adult, so this implant not only for the children, you actually can use for the adult 70 years old. I have the oldest patients which is implanted at the 72, 23 years old. For the adult, same thing. If you have any problem, go and check. Okay, we will try to help you out. to help you out to see what we can help you to restore your hearing, so that you can back to verbal communications.
Okay, thank you, Professor Tang. So it's very important to detect early if there's even a doubt of their hearing level or the hearing status. Just get it checked out. Never know, you never know. There is another question here, Professor Tang, regarding cochlear implant, because mainly it's done in the pediatric age group. So there's a question, how long do they normally have to stay in the hospital for that surgery? At the moment with the concern of COVID, so they don't want to stay very long inside. So what is a normal stay in the hospital after the surgery?
Usually, for my patients, depends on depend on the whole procedures, whether they have any complications or not. If a straightforward case, most of the time, I would say you basically stay in the hospital for 1 or 2 days only. Usually you will admit surgery done. After surgery done, the next day, is everything okay? No problem. Patient, especially for the children, they can eat, okay? They can crack their food, no fever, nothing. The next day can be discharged already. So discharge, if everything well, if the wound is very nice, less than a week, they actually can switch on to put the sound processor, then can start to intervene. So most of the time, you can do that quite early, provided the surgery have without any complications. So the next day, most of the time, I think I would say 90% of my patients the next day will get discharged, and then they can get switched on less than a week most of the time, because the surgery is getting more and more common in this part of the world. So it's not something like very frightening. They always think that cochlear implant, to put some very small thing in the cochlea, is very complicated. Actually, it's not. Okay, it's not. Just depend on how do you look at it, how do you deal with it. The experience do take very important part in this, how to manage this kind of patients here. So not too worried about how long a patient will stay in the hospital. If everything well, by a day, okay, after surgery, most of the time can be discharged.
Wow, that's very, very quick. So I think it gives some sense of safety and calmness to the parents out there. So there's just a very short stay in a hospital for something that can actually change your children's life. Right. Just to continue a bit from there as well, there's a question here. I think it's very relevant to us here in Malaysia and Sarawak as well. How much is the device for all these hearing implants, Professor Tang?
Yeah, the device is quite expensive. So a few companies are in doing this, selling these implants. So far, I think we have 4 companies doing this implant. So all the companies, their implant are all very good. Okay, it's just some implant have different kind of features here. But of course, different implant come with different price. So the price range, okay, the normal price range is around 70 to 80 K ringgit Malaysia, 70 to 80,000 ringgit Malaysia. Of course, that sometimes you might get some discount. You're doing the other side, or sometimes you might get free one side. Okay, if you doing both sides the year. And the price, of course, we need to discuss with a company. So roughly range of the price in the market, okay, with a different company around 17 to 80, even sometimes out to 85K. So you can look through the company. We have the company called Medel. We have a company called Oticon. We have a company called Cochlear. We have a company called AB Advanced Bionic. So they have different company. They have all devices are very good. So there's some company have some device have a bit different features, but so you just have to look at it, look around, and then you just have to scout around, see which one is more. So for me, it's all the implant, they are good, just to see what sort of devices that you think to have it.
Okay, thank you, Professor. And I think there's now a growing support and awareness to cover the cost of these implants. Yeah.
Diane is ready.
Yeah, we have some technical issues about the slides. Yeah, Kevin, can you share the slides, Kevin? If you don't mind.
Can EB do that? Because I am using the iPad here.
All right. some technical issues, yeah.
Okay, Kevin, any
So
more
what's the-
questions for me?
So far, yeah, okay. There's another question here. So we did mention about the newborn screening, and we saw the picture. We saw the picture earlier. Is it a very quick procedure? Would the baby feel any pain?
Oh,
I think
newborn screening is a very quick procedure. I think less than 5 minutes you have done the things there.
Oh,
There's no
that's
pain.
very fast.
Basically, you just less than 5 minutes. You just put even the nurses all can do it, like in SGH. You just put this OE machine, a patient bone, just put into the ESC. You just like measure temperature, measure like a temperature probe like that. Just put in the ear there. You just hold for a while. You see come back the waveform whether pass or fail. But of course, if you're doing more high tech, like this Bera kind of, it's also nothing invasive. It just basically you put the electrode, okay, stick to the scalp, the mustard region. After a while, like I showed the photo just now, there's nothing like a needle pinch into the skin. So it's basically just the probe with some adhesion tap on the scalp. That is a bit more can stand longer. That one Bera you need to do like 30 minutes, okay, 45 minutes, but the child had to be sleeping. So in order it's not moving, if moving, they might disturb the waveform to see. So it's something that all this kind of intervention, this kind of investigation checking is not invasive. It's a very quick procedures for us to get to assess and then to have a proper reading about the hearing.
Okay, thank you, Professor Tang. So I think we're just waiting for Dr. Diane to share her slide.
Yeah, can we try for one more time, please? I'm sharing the screen already.
Okay.
Yeah, can you see, Kevin, before you proceed with the to show them? Can you see anything here?
Yeah, I can see that you started.
Yes,
full screen now. You can see your full screen now. You just click on full screen.
Okay, all right. Hold on. Can you see now?
I can see your first slide.
Okay, can you see?
But it's not moving yet.
Okay, all right. How about my second slide? Yeah, how about my second slide? I'm on my second slide right now.
Tak dapat. Yes, now we can see Otalgia, Otoria. Yep.
All right. I think it's a bit of lagging. It's okay. I can just talk and while I'll scroll and waiting for the slides to move to the next one. Okay. All right. We can just proceed. Yeah. Kevin.
Yeah, sure. Go on. Thank you, Dr. Diane. Yeah.
So basically, as Prof. Tang mentioned earlier on, we have three parts of the ear. Basically, is outer, middle, and also the inner ear. So these slides, which I'm going to show, is going to include the common infections in children and also in adult. So when we say children, why is it so special about children? Yeah, because of the anatomy, it's different from the adult. So usually in adult, if you can see my slides, which I'm on now, I'm explaining about the eustachian tube, which is much shorter and more horizontal than in adult. It means that whenever the child feeds, yeah, or bottle fed while the mother bottle fed the child, so or any infection in the oropharynx or on the tonsils from the nose, it will go direct to the ear, yeah, because of this anatomy in children compared to the adult. So hold on. So because of this, there are few symptoms which are commonly commonly complained by the child, yeah, to the parents, yeah. Mainly what the pain, and the child will have they will be very irritable, fussy, and they have trouble sleeping.
Sorry, Dr. Dang, we seem to have lost you here. Are you still there?
Yeah, some have unexplained fever because in a speaking age group, yeah, they do not have the irritability and whatever the notice that a child will have. So even if they call or they respond after, they are some has a visible even if the child is very active, the mother or yeah, can you hear me now? They'll be complaining of a ear discharge coming out from the ear. All right. So who is at risk? At risk of having this ear infection? So we can have usually those child who are less than 5 years of age. They'll be able to complain of pain and they'll tell their guardians or parents. But those the who attends the daycare, for example, yeah, they have a higher risk than those who just stay at home and they are cared by their mates or parents. And children with a history of allergies, for example, with allergic rhinitis, eczemas, they are more prone to have a ear infection because of this. And the other group of children who are exposed to the risk of infection are those who are in a group of a child who are exposed to a cigarette smoke or a passive smoking. And those who are not breastfed, yeah, because as you know, breast milk has an antibody that helps fight the infection naturally. And for those babies who are being bottle fed, so as I've mentioned earlier on, yeah, if they are fed lying flat with a horizontal eustachian tube, so these are all the factors which contributes to the ear infection in children. Okay, so the next one will be, there are a few types of infection. Yeah, now we are going to the outer part of the ear. So what are the infections of the outer ear, or we call otitis externa? This can be present in adult and also in children. So you can have bacterial infection, fungal infection, and some viral infection which cause otitis externa, and also some skin or dermatologic condition which contributes to the inflammation and also infection of the outer part of the ear. All right. So risk factors. So what are the risk factor to have for patients to have this? So basically, the factor, for example, narrow ear canal, excessive wax, and moisture, particularly when the child goes for a frequent swimming lesson, for example, or those who are in high humidity area. And as you know, some have frequently cleans their ear with cotton bud, yeah, fingernails, and those who are on hearing aids and also earplugs. This can lead to infection of the outer part of the ear as well, because it will traumatize the skin and also the area of the inner part of the ear. As I've mentioned earlier on, skin problems. So the common symptoms, again, they are otorrhea, yeah, otalgia, pain, or hearing loss. So hearing loss can lead to a few complications later on, and also the child will complain of ear itchiness. So for otitis externa, can you see the slides? Kevin, can you see the slides?
Yes, we can. Yes.
Yeah. So otitis externa, as you see in the slide, which is shown, yeah. So you can have a swollen external ear canal, and also there is a presence of pus. And you can see it can occlude the whole ear canal, like the first picture on the left side. Then treatment. So for the treatment of otitis externa, same with a child and also in adult, we'll give oral antibiotics and topical eardrops and some antihistamines and also some analgesia. So CMC, for those who are, we don't usually give chloramphenicol eardrop because of the high incidence of allergic reaction, yeah. And so for those who are allergic to CMC, eardrop usually will give a substitute for it. And here sometimes you want to treat the otitis externa, for example, yeah, you give the doctor will give a CMC ointment, but end up having a more it flares up, the infection flares up. So you know that this condition is caused by the allergic reaction of the CMC eardrop. So this is an example of an ear toilet which is done in our clinic. Yeah, there's a microscope, suction machine is also a probe, and we'll clean the ear thoroughly. Then to prevent the occlusion of the ear canal, which I've shown earlier on in the few slides earlier on, we will clean the ear, yeah, and then after that we'll put a ear canal packing, or we call it a earwig. It's like a tampon, so we just put it in to prevent the ear canal from obliterating, yeah, to prevent it from occluding. Yeah. And we'll take it out after usually after 2 or 3 days. Okay, the next one, the next slides, which I'm going to show is the, you can see there's a otomycosis basically it's a fungal infection of the external ear canal. And again, common complaints will be pain, ear itchiness, ear discharge. The same, yeah, the same symptoms, but they can have differential. So in order for us to diagnose, we have to do an otoscopy. So the symptoms is the same, but the diagnosis is different and treatment is also different. Okay, so the next slide, again, this is an example of otomycosis, and usually we'll give a topical eardrop for about 2 weeks, and also a local application in the external ear canal, which is the antifungal cream. So the next slide will be, it shows the infection caused by this condition is called a Ramsay-Hunt syndrome. And you can see there's a vesicle over the pinna and also the external ear canal. And patient will have a half side of the facial drooping, or we call a facial nerve palsy. So the treatment is usually we'll give a antiviral medication and it's self-limiting. It'll go off after taking all the medication that we are giving. So the next one is, this is not common in children, but I just include in the presentation just for us to know there are a few conditions, just a simple otitis externa, but it's actually one which the one which is not malignancy, but it's actually a very aggressive infection and potentially life-threatening for the patient. Yeah, this is usually in those who have immunocompromised state, who has diabetic, and also in elderly. So you don't see this in children. Mostly is in the older age group. So in this condition, it requires radiological diagnosis and to be treated with prolonged IV antibiotics. Okay, as you can see in the picture, there is a granulation tissue at the floor. Yeah, at the floor of the external ear canal. So this is just the criteria for the diagnosis. It's called a Levinson criteria. We can they are listed on the slide. Yeah, the patient can have refractory otitis externa, severe nocturnal otalgia, very painful ear. Uh, as again, otorrhea, granulation tissue, which can be visualized during otoscopy, infection with pseudomonas, and those who are immunocompromised or diabetic patient, and with a positive bone scan. So as you can see here, there is a area of erosion filled with granulation tissues on high resolution CT of the temporal bone. Okay, the treatment is a prolonged treatment with antibiotics. We'll give IV ciprofloxacin, which is about 2 weeks, and also continued with oral ciprofloxacin for the next 4 weeks. So this the next slide. Okay, the next slide will show this is how a bone skin will look like. So there'll be an uptake of the area of the infection. All right, as you can see here. Okay. All right. Next, we have infection in the middle ear. Can be in both children and also adult. Yeah, the infection can occur in both age group. So before we proceed, there are two different types of tympanic membrane or eardrum perforation. One is the tubotympanic, which is what we call a safe type, and another one is eticoantral, yeah, at the superior part of the eardrum or the tympanic membrane. So the differences between both of these type of perforation are listed here. So you can see the discharge in tubotympanic or safe type is profuse, mucoid, and odorless. Whereas for the unsafe type, the discharge is scanty, purulent, and very smelly. Perforation in tubotympanic is central, in eticoantral is marginal or at the attic region, which is the superior part. Granulation is more common in unsafe type, and polyps usually red and fleshy in the unsafe type. So cholesteatoma, where there will be a granulation tissue and erosion of a surrounding structure of the ear will be present in the unsafe type, and complications are more commonly seen in the unsafe type, and both showed conductive deafness, but in the unsafe type, you can see there is an element of sensory neural hearing loss. So the next slide will show the otoscopy of the acute otitis media. So there'll be inflammation at the tympanic membrane, and there will be a middle ear on otoscopy. The ear will be very, very painful, yeah, because the pus is accumulated at the middle part of the ear. So as I've mentioned earlier on, the risk factors for those children who are in daycare, bottle feeding, and with some adenoids, yeah, a lymphoid tissue at the back of the nose which is enlarged, so they can have all this acute infection of the middle part of the ear. So the acute symptoms in children will be fever, very irritable, and they'll be crying all the time, and the child will be usually pulling the ear, trying to tell them that the ear is painful, or trying to relieve the pain, but it doesn't work for them. And some will have a vomiting, which is a sign which is the parents have to look for if the child has all these symptoms. They have to bear in mind that there might be a acute ear infection. All right. For the next one, the next slide, as you can see, there are few stages in acute otitis media. One is the hyperemia or the inflammation of the tympanic membrane, exudation phase where there will be bulging, as you can see, and exudation, which is there's a bulla formation, and when it bursts or it's perforated, there'll be a suppuration phase where there'll be a ear discharge in the ear canal, which is the outer part of the ear. So, what are the treatment for those children with otitis externa? So, what topical eardrop, which is the ofloxacin eardrop, and oral antibiotic, mainly augmentin, will give some nasal decongestion, which is a topical nasal decongestion, and also analgesia for symptomatic relief. So, for medical personnel, when do you refer these children who have been crying day and night, having high fever, and also very irritable at home? So when you see the child, the ear is discharging, there's a pus coming out from the ear, and the mastoid area or the post auricular area is red, inflamed, yeah, refer immediately, because this is a sign that there is a complication. It means that the infection goes beyond the area of the middle part of the ear already. All right. So if this the picture previously, which I've shown in the slide, there is a complication of otitis media, which is a mastoiditis. All right, so don't when you see this type of patient, don't send them back home. Please refer to ENT immediately. All right. For the parents, as for the doctors or MAs who are seeing the child in the clinic, yeah. So for the parents, when should they consult the doctor? So if you think your child has an ear infection with all the symptoms that I've mentioned earlier on, or has other serious medical problem, so call your doctor immediately. And even if there's no ear discharge coming up, but the child seems very ill, vomiting, and which is younger than 6 months of age, usually they won't tell you the ear is painful or not. So, and has fever, so just call your doctor and go to the clinic immediately. So some have a very obvious signs. For example, just now as I've mentioned, a swelling behind the ear, which could indicate some mastoiditis. And sometimes the mom will tell you that the child seems to be very sleepy after few hours or a day of being very irritable, and suddenly the child is so sleepy and suddenly has a skin rash. So these are the telltale sign that the parent should bring the child to see the doctor. So apart from that, what are the other clue that there might be something wrong with the child? So when the child is unable to hear, when you call the child is unresponsive, or you have to call the child more than 10 times, for example, yeah, go and seek a doctor's go and see the doctor for consultation. So, and last but not least, if the patient remains in a lot of pain, yeah, after giving one dose of analgesia, just bring the child to see the doctor. Don't delay, because the infection, the spread of the infection can be very, very fast in children. All right, for the next acute otitis media, there'll be a chronic state of the otitis media. What do you mean by chronic? Chronic means when the symptom exists for more than 3 months, with chronic discharging ear, less ear pain, but more of a reduced hearing. So common organism is Pseudomonas, and also there'll be a reservoir sign if you see the otoscopy. So this again another example. This is a large center perforation, but there is a dry ear canal and also a middle ear. So for those who have a chronic mastocytitis, management will be a topical. We'll give a eardrop as well. We'll give a oral antibiotic and frequent ear toilets. So when we have a child with a chronic discharging ear after a few course of antibiotics, oral antibiotics and eardrop for more than 3 months, so we'll proceed for the high resolution CT scan of the temporal bone. Why? Because we want to see whether there's any complication arising from the infection, mainly mastocytitis or cholesteatoma. So if there is, then the surgical intervention will be doing a cortical mastectomy to eradicate the disease part of the ear. So for cholesteatoma, so in a severe form of otitis media, there will be a cholesteatoma formation as a result of complication of the chronic otitis media, and also there will be a bony erosion, and subsequently patient will have a hearing loss, scanty discharge all the time, and also occasionally having a ear pain. So as you can see here, in this slide, there will be a attic cholesteatoma, which is at the superior part of the tympanic membrane. As you can see, there will be accumulation of keratin debris at that particular part, and it goes all the way to the middle ear to erode all the structures in the middle ear if it's not treated. So as you can see here, there's a granulation tissue, there's erosion of the ossicles and all that in the CT scan. That's why we need to do a CT scan to look for all these complications. So as I mentioned, surgery, modified radical mastectomy. So when we talk about all this ear infection in children, so what we are trying to prevent is the complications that might arise from the infection. So there'll be a few complications, which is the intratemporal, which means that it's confined to the temporal bone, namely mastocytitis, petrositis, and facial paralysis, and labyrinthitis, which is the infection of the labyrinth. So you can see here from this slide, so superiorly you can see the infection can cause an intracranial complication, developing a cerebral abscess, subdural abscess, and also a meningitis when it infects the meninges. And also it can extend to form a cerebellar abscess and also extradural abscess. And here you can see it can affect the lateral sinus and cause thrombosis. Here mastocytitis and erosion of the ossicle and middle ear can cause facial paralysis affecting the labyrinth. So for the extra cranial complication, based on the of the abscess and infection, we have a very fancy names for it, but basically it is just a name to describe which area extracranially the infection is going. So for example, we can have it going to the inferior, causing the dissolved occipitalis abscess, and superiorly, which can cause acute apical inflammation or infection of the petrous bone, and anteriorly it goes to the zygomatic, and posteriorly, as I've mentioned, mastocytitis, and medially to the inner ear, it can cause all these labyrinthitis and labyrinthine fistula. So the diagram showed in the slide, here you can see the propagation of the infection, which could lead superiorly, inferiorly, posteriorly, and medially. Okay. So these two pictures showing some of the abscess formation resulting from the ear infection. As you can see here, the post-auricular area, and also it can extend down to the neck region. So you can see it's very, very dangerous. From the ear, it can go to the posterior part and along the neck to the inferior part of the neck. And if it's not treated, it can cause a sepsis. Here you can see acute mastocytitis in a pediatric patient. And on otoscopy, if you see this child here with a bulging posterior auricular area and also bulging part of the external ear canal, on otoscopy, please refer immediately. So this is the next slide is just to show acute apical petrositis. It's a rare complication, but we cannot miss this because in of 6 and also a called a Grady-Negos syndrome, which consists of ipsilateral facial or retrobulbar pain, lateral rectus palsy, and with a persistent discharging ear. So here I'm going to show a child with a facial palsy as one of the complication of ear infection. Yeah, the child can present like this. You ask the child to close the eye. The child won't be able to close the eye at the affected side because there is a facial palsy. And again, the second, which the child has a facial palsy as well. Yeah, as you can see, the child is unable to close the eye fully with a loss of creases at the nasolabial and also the side of the mouth on the affected side. Here is axial section of temporal bone CT scan showing soft tissue around the ossicular structure and also at the middle ear cavity. Yeah, this is basically on the left side of the ear, and also there is a mastocytitis present, visualized in the CT scan. So the next one, intracranial complication, which I've mentioned earlier on in the slides. So this is just to show some of the CT scan, which shows a intracranial abscess, as you can see here, and also here. So these are all a result of the autogenic cerebral abscess. So we cannot take the condition of ear infection lightly because the patient, the child, can end up having a cerebral abscess. Okay, and it's very fatal. And as I've mentioned, as the degrees, as the disease progress to infect the labyrinthine area, the patient can present with room is spinning or having a giddiness and then unable to walk properly. So these are a sign of the complication of the ear infection. So for the long-term complication, child can have a permanent loss of vestibular and cochlear function. So the child is at risk of having a hearing loss due to this, all of this untreated ear infection. So prevention is better than cure, which is very correct, very true. So for parents, how the ear infection can be prevented. So number one, again, frequent hand wash. If it's possible, please avoid bottle feeding with a child lying flat, which I've explained earlier on. Bottle feed. From a bottle feed to a cup by 1 year of age, and do not smoke in front of the children, because those children who are secondary or secondhand smokers will be exposed to the smoke, and hence this will increase the risk of ear infection. And get the influenza and the pneumococcal vaccine from a nearby health center. And also, if the child is having frequent ear infection, try to reduce the use of the pacifier, or what we call as a soothers. This again also contribute to a repeated infection in children. So I end my presentation here, and thank you for your attention. So you have any question, just type in the chat box. Thank you.
Yeah, thank you, Dr. Dayang, for the very interesting and also comprehensive talk about ear infection. So now we all know that ear infection shouldn't be taken lightly. Just a couple of questions here for Dr. Dayang. Now, one mentioned earlier, because nowadays a lot of parents bring their kids for swimming, and it was mentioned earlier that swimming can be one of the cause of infection. So what can we do to prevent ear infection in kids who frequently go for swimming classes and lessons?
Okay, first of all, it's not wrong to send a child to swimming classes. The thing is that, number one, the ways that we can prevent ear infection is to prevent the drainage of the water inside the ear canal. All right, so this can be prevented by using an earplug, which you can buy at a pharmacy. So make sure the child wear a earplug. All right, and also make sure when the child has a flu or some upper respiratory tract infection, make sure it's treated before you bring the child to go for the swimming class, because this can block the eustachian tube, which is a tube which connects the back of your nose to the ear. So if that's blocked and you don't take care of the ear of the child with all the infection going on, it can lead to a infection of the ear. All right.
Okay. Thank you for the answer, Dr. Dayang.
Any more questions?
Another one is regarding earwax. There was a question he asked regarding how do they deal with earwax? Should they dig the ear? Should they use the metal thing? Okay,
it's a no-no to use a metal probe to expel the earwax. It's a no-no to use a cotton bud. So physiologically, the ear will be able to expel the earwax by itself. We have a regulatory system whereby the earwax will be able to expel out from the ear naturally. What we can do is we can just wipe the outer part of the external ear canal to clean the earwax. Another option is sometimes, even if the child or adult who doesn't use the cotton bud, for example, they can still have a condition which we call a impacted earwax. So there are few technique of removing the earwax. Number one is we can give usually a doctor will give a eardrop to soften the earwax, and it will be expelled by itself. But if the earwax is too compact and it can cause a pain, intense pain to the patient, we'll try to remove it immediately by way of syringing the earwax. Yeah. All right. So this is to be done by a trained person, the ENT doctors, to avoid a complication, for example, a perforation of the eardrum. And also, having said that in mind, the complication of removing the earwax by way of syringing is to be done at a certain temperature of water to prevent that the patient going giddy during the procedure. All right. So yeah. So my answer is no, you cannot. Yeah. So you can ask the doctor to have a look at your ear, and the doctor will prescribe an eardrop to soften the earwax. All right.
Okay,
Any
thank
more
you for
questions,
clarifying
Kevin?
the issue, Dr. Dayang. Thank you for
Yeah.
being very clear. Just
Yeah.
one question which I think is very relevant because me and you, we are wearing earphones now. So there's a
Yeah.
question here. Is it safe to use earphones for prolonged periods but with sounds less than 90 decibels?
Less than 90 decibels.
Yeah.
Okay.
So is it okay to use in the long term? Yeah.
Okay. We have a condition which we call a noise-induced hearing loss. After you are exposed to many years of noise, not only using earphone, but let's say you're working in a factory or a workplace which is very, very noisy with mechanical and machineries going on, you can have the condition called noise-induced hearing loss. So for those who are wearing earphones, headphones, like what we are using now, yes, it can cause, but it varies. Some have a device which can detect a safe noise exposure. Yeah. So the device or the phone or the laptop will be able to monitor the usage or the exposure of a noise or a sound used by you in a daily basis. Yeah. I won't mention the name of the product of the phone or a particular brand, but there are. And then if they are unable to avoid the usage of the hearing device, what we would advise to the patient is that try to reduce the number of frequency of usage. Try to lower the frequency of the loudness of the sound. And also if the patient, or if you're working in an area which is in a factory, or for example you are using in customer service, you have to use this every day, I advise that you have to get checked. It means that you have to go to see the doctor, check the eardrum, and also do a hearing test, which can be done in the ENT clinic or a audiology center. Yeah. All right.
Okay, I think just one last question for Dr. Dayang here. There's a question here regarding vertigo. So they're asking for prolonged on and off vertigo. Could it be one? Could be the year, could be the cause of that. On and off vertigo.
Yes.
Could it be one of a ear disease, symptom of a ear disease? Yep.
Okay. Yeah, we have a lot of patients coming to our clinic for vertigo. So vertigo, for those who are not familiar with the word vertigo, it means that a patient will be having this sensation of the room spinning. Yeah, the room is spinning, or the patient feels that he or she is spinning. So in a balanced system of human, there are few factors which contributes to the balanced system of human being. One of it is a hearing. Yeah, hearing. There's a equilibrium vestibulocochlear function which contributes to the balance system. Number one. Number two is your eyesight. Yeah, it contributes to the balance system. Number three is your sensation. Number four is your balance, your hearing, your eye, and also all these other sensory input to contribute to the the balance. So if any of those system which is defect, so yes, you can have a vertigo. So when a patient comes to us, usually we look for a symptom which is related to ENT. Yeah, for example, any other ear discharge, which yeah, sometimes it's a complication of ear infection, as I've mentioned earlier on, labyrinthitis, or there's some imbalance of the balance system of the ear. Yeah, if we rule out everything, we say it's not ENT cause, and we will refer this patient for further investigation. Yeah, especially we will refer to the neuromedical side to further investigate. Because we can safely say this is not ENT cause. But then again, sometimes it's vice versa, means that the neuromedical gets the vertigo patient, they rule out the cause of vertigo contribute by the central part, and they refer to us to look for the cause caused by the vestibular system in ENT. All right. Okay.
All right. Okay. Thank you, Dr. Dayang. So I think that is all the time
Kevin,
that we have for. Yeah. So that's all the time we have for today. Just before we leave, just a reminder to fill in the details in the Google Sheet form that's in the chat box for your attendance and also your e-certificate. Before we end this session, I would like again to take the opportunity to thank the organizing committee. Our distinguished speakers are Professor Dr. Tang, who has to leave early because he has an emergency in the hospital. Dr. Dayang here as well for the excellent and very informative talk. And more importantly, to you viewers for joining us here today. I've gone through the chat box. We have viewers from all around Malaysia, from Kudat, Taiping, even Penang as well. So we hope that this talk was beneficial to all of you. So thank you again. Stay safe and take care. All right. Bye-bye.